Hello, my name is Emerald McGee. This is my final project for the Wake Technical Community College 2025 Continuing Education Paramedic course. Today we're going to be talking about oxygenation. First of all, what is it? Oxygenation is the oxygen in the environment being able to get into your body and then into your tissues, where it is used for some very, very important vital processes. When we first get on scene and we're assessing a patient, the first things we assess are the ABCs. Do they have an airway in order to move oxygen into their lungs? Are they breathing, actually moving oxygen into their lungs? And do they have circulation? Are they circulating oxygen through their body to their tissues? These are the things that keep patients alive. So in order for oxygenation to occur, the first step is ventilation. So I need all of you to take a deep breath in and out. That was ventilation. So the first step, moving air into the lungs and then out of the lungs, allows us to get oxygenated gases in, which allows respiration, the movement of those gases into the bloodstream. That's external respiration, the exchange of gases between the environment and the organism. And then the internal respiration, exchange of those gases between the blood and the tissues. And obviously the whole time, every time we exhale, those waste gases are leaving the body. So we're bringing in good stuff, inhaling the good stuff, exhaling the bad stuff. Now, for the anatomy necessary here, we're looking at the entire airway. If you cannot ventilate, then you cannot oxygenate, because you can't move oxygen-containing gases into the lungs if you can't move any gases into the lungs. More importantly, here are the lungs, specifically the alveoli, the little sacs where the gas exchange actually happens. They're kept open by a substance called surfactant, secreted by specialized cells, and they're wrapped tightly with these capillaries. They're very, very small and thin, with a lot of surface area between the two to maximize gas exchange. Once the oxygen does get into the blood, it is bound to a protein called hemoglobin in the red blood cells. Each hemoglobin has 4 points where a gas can be bound to it, not necessarily oxygen. And each red blood cell has approximately 250 million hemoglobin molecules in it. So each one of your red blood cells can move about 1 billion oxygen molecules. Now, once that oxygen is bound here and is along for the ride, it goes to vital tissues. Now, these tissues need oxygen because they are using it for the production of ATP, adenosine triphosphate. The brain and heart, in particular, are very high energy demand organs. They are constantly working, they are constantly performing these processes that require the input of a lot of energy. So they're very, very sensitive to changes in oxygenation. What the brain and heart are doing with the oxygen is aerobic metabolism. They are producing ATP at a rate of 32 molecules of ATP for each molecule of glucose when we have adequate oxygen. If we do not have adequate oxygenation, we switch to anaerobic metabolism, where we produce a net of 2 ATP molecules for each glucose molecule, which is significantly less efficient. We've gone from 32 down to 2. Also, we're producing 2 pyruvate molecules each time we do this. In aerobic metabolism, those are recycled. The body disposes of that properly. Everything works great. When we don't have enough oxygen, those hang around and eventually get converted to lactate or lactic acid. Now, we've all heard of lactic acid accumulating and causing muscle soreness when you exercise, particularly anaerobic exercise. That's because those muscles are performing anaerobic metabolism. They're not getting enough oxygen to meet their demand. And that's all right when your muscles are doing it, but you don't want your brain or your heart doing that, because that's just going to cause a lot of issues. It can cause cell death, tissue death, and eventually systemic acidosis. And your body's going to try to compensate for this as much as it can, but really what you need is oxygen. Now, hemoglobin, which we mentioned earlier, that carries the oxygen in the blood, does not always carry the same amount of oxygen. The oxyhemoglobin dissociation curve shows how much of the hemoglobin is going to pick up oxygen at a specific partial pressure of oxygen in the air that is being inhaled. There will be a reduced affinity, meaning that the hemoglobin is less likely to hold onto oxygen at higher CO2 concentrations, lower pHs, so when we're more acidic, and higher temperatures. I like to remember that as when we're exercising. We've got a higher pH because of that lactic acid buildup, and we've got a higher temperature because we're just exerting ourselves. Muscles produce heat. And that's a good thing, that the hemoglobin lets go of oxygen more easily in those conditions, because we want that oxygen to get off the hemoglobin and go into that muscle tissue so that we can start doing some aerobic metabolism and rebuild some of the glucose that we lost, or the ATP that we used to do that exercise. Now, in the field, in the pre-hospital environment, the way that we measure oxygenation is with pulse oximetry. It's not a lot of people's favorite device that we have on the ambulance because they're considered to be kind of unreliable and inaccurate at times. Half the time the monitor is beeping at you, it's because of this thing. There are a lot of things that can cause the SpO2 to read inaccurately. If the tissue where you're sampling isn't being perfused properly, if the light can't be transmitted properly due to, say, dirty fingernails or nail polish, if the patient's moving around too much, if there's too much ambient light, it can just be too bright where you are for the pulse oximeter to read properly. But when they do read properly, what they tell you is what percentage of the hemoglobin are bound to something. It's not necessarily oxygen, just something. Hemoglobin that is unbound and hemoglobin that is bound absorb different wavelengths of light. So the SpO2 is transmitting red light and infrared light, and looking at the difference between how much of each is absorbed to calculate what percentage of the hemoglobin are in the bound versus unbound states. And that change is typically pretty predictable over the course of the cardiac cycle, like with our pleth waveform here. We see a sharp increase at the beginning during systole that starts to decrease, a little bit of a bump there that's called the dicrotic notch, and is when the aortic valve closes. And then during diastole, it continues to decline until we reach the next heartbeat. That can be a useful tool to tell whether or not a heartbeat that you feel or see on an EKG is perfusing the tissue where the SpO2 is being measured. Maybe it is, maybe it isn't. Maybe it was premature and the heart didn't have enough time to preload, but that it didn't perfuse despite you seeing electrical activity. Other things that might affect SpO2, if your patient has carbon monoxide poisoning, their SpO2 will read high because there is something bound to the hemoglobin, carbon monoxide. It binds very tightly to hemoglobin, about 240 times as strongly as oxygen. So that hemoglobin binds on very, very tightly and doesn't let oxygen on, and that means that the patient their tissues aren't being oxygenated. What these patients need is transport to a hyperbaric oxygen chamber, because increasing the partial pressure of oxygen as much as possible will increase the amount of hemoglobin that is saturated with oxygen and deliver more oxygen to their tissues. Patients who have COPD will chronically have low oxygen saturation, but they may not be presenting differently. They may be presenting their baseline, maybe even at an SpO2 where other people would be presenting agitated or altered. And Cyanide poisoning interferes with the production of ATP, but not the use of oxygen. So the oxygen in the blood stays in the blood. It's not being used by tissues, so it just keeps circulating, and SpO2 will read high despite tissues not functioning correctly. The clinical presentation of a failure to oxygenate kind of depends on the tissue that's not being oxygenated. Now, it is rare that an individual tissue is not being oxygenated, and that's typically more of a perfusion issue. That'll be a compromise of circulation to that tissue. Oxygenation tends to fail systemically, which means that it will affect the tissues that are most sensitive to changes in oxygenation first. That's going to be your heart and brain. For the brain, we're going to see agitation and altered mental status, followed by loss of consciousness. For the heart, we are going to see tachycardia, we are going to see peripheral vasoconstriction, we're going to see autonomic nervous system activation, epinephrine, which means pale mottled skin, maybe sweating. These are your pale, cool diaphoretic patients. It will look a lot like hypotension and shock, but these patients' their blood pressures are going to be normal or high. They're not hypovolemic, they're not hypoperfused. It's just that the tissues that are getting enough blood aren't getting the right stuff in the blood. They're not getting enough oxygen. Another reason that oxygenation might fail is that the lungs specifically are not being perfused. That's a ventilation perfusion mismatch or VQ mismatch, and that can be due to a pulmonary embolism or bleeding in the lungs or cardiac arrest. During cardiac arrest, the lungs obviously are not being perfused properly because nothing's being perfused properly. There are a few chronic conditions that affect oxygenation, particularly by affecting the alveoli. Emphysema causes the alveoli to collapse. They aren't quite as elastic. They don't expand as much when you breathe in, and therefore you're not, oxygenating as much. Bronchitis. We have inflammation and constriction of that the smooth muscle in the airways, and the secretion of mucus, which causes blockages. We're physically blocking gases from getting into those alveoli for exchange to occur. Similarly, if a patient has drowned and water has gotten into their lungs, it can wash out the surfactant that keeps the alveoli open. With these patients, you might see a sort of bubbly, frothy, but clear sputum in the mouth when you are compressing or ventilating. And really positive pressure ventilation is going to be the best thing for those patients. We already talked about carbon monoxide, but really carbon monoxide detectors, if your agency doesn't have them, you should ask for them because it is colorless, odorless. You will not know it is there until you start getting a headache and just kind of feeling funny. And you won't know what it is right away until it's starting to affect your judgment, and then you won't be able to save yourself, and you will be in a dangerous situation. This is very, very dangerous to us. We get called out for these patients who have experienced carbon monoxide poisoning, and we don't know that's what it is until we get there, and then we're already in the environment. So just be careful. As for treating failures to oxygenate, give them oxygen. We do this all the time. This is a BLS level skill. We can start off with a nasal cannula at 1 to 6 liters. We get non-rebreather up to 15 liters. The BVM, if we also need to assist ventilations, we can go up to 25 liters per minute. And then the CPAP mask, where we can go up to usually 7 to 10 PEEP, which is... With CPAP, we're having continuous positive airway pressure, so we're putting pressure into the lungs to help inflate them, to expand those alveoli to allow gas exchange. If the patient has had their alveoli collapse, due to, say, COPD or the surfactant getting washed out for those drowning patients, or pulmonary edema. This is a very good way to relieve those patients. For some pharmacological interventions, we still have albuterol from our ALS intervention or BLS interventions. If we have a patient who's having wheezing, bronchospasms, that's still a really good way to stop those. We also have ipratropium bromide or Atrament, which can help with excessive airway secretions. We're still going to give epinephrine for patients with suspected allergic reaction or, in some cases, very bad asthma attacks. Solumedrol, a corticosteroid, can help with inflammation. It can reduce that, which can open up the airway and allow the patient to breathe. And then for severe bronchospasm, or the smooth muscle in the airway being overly constricted, we can give magnesium sulfate for some smooth muscle relaxation. Problem with that is that it relaxes all of the smooth muscle, which includes vascular smooth muscle, so it will drop their blood pressure. Just be aware of that. Know your local protocols for what minimum systolic blood pressure they need to have in order to give mag sulfate, and just keep an eye on their pressure.